Hello, everyone. Welcome to today's webinar, Navigating Balance, a Compass to Prevent Falls, presented by the Fall Prevention Community of Practice. My name is Christina Chico, and I am a project coordinator at the Ontario Neurotrauma Foundation. ONF sponsors the Fall Prevention Community of Practice and its online platform called Loop. Loop is a place where fall prevention practitioners connect. Please visit us at fallsloop.com. Marguerite Thomas also joins us on the line. Marguerite is the coordinator of the Fall Prevention Community of Practice and will be assisting with the webinar technology. Before we begin, I'm going to give you a quick review of the webinar technology that we are using today. This technology consists of two parts. The audio is provided through a telephone conference line, and the visuals are provided through a web platform. Both the phone number for the conference line and the link for the web platform were sent to you by email after you registered for the webinar. If you have questions about the technology at any time during the presentation, please feel free to type them into the chat box on the left-hand side of your screen. You can also email Christina@onf.org, which is CRISTINA@ONF.org, and we'll work with you to resolve your technical issues as soon as possible. This webinar will contain opportunities for participation. There will be a question and answer period at the end. If you have a topic-related question during the presentation, please type them into the chat box. During the Q&A, questions will be read out loud to the group. If you would prefer to ask your questions over the phone, we will provide the instructions to unmute yourself during the Q&A. The webinar is being recorded, and a YouTube link will be circulated to all registered participants in about a week or so. The presentation slides will also be distributed by email after the webinar. I would now like to introduce our presenter, Deepha Ramwalt. Deepha graduated in 1999 as a physiotherapist and started her career in the Department of Neurosurgery in trauma care. She is a certified member of the Neuro-Developmental Treatment Association and has advanced level training in NDT, Bobath treatment techniques. She has also completed the specialized training necessary for pelvic health rehabilitation. After working in long-term, retirement, hospital, and community settings, she is now practicing clinically full-time. Deepha strongly believes in a holistic approach. Clinically, her practice revolves on the platform of the science of neuroplasticity. She works to restore functional movement with postural and motor control and to assist clients in attaining their goals. Deepha, you may unmute your line now and take it away. And it's been a pleasure getting to know you as we've coordinated this webinar for today.
Thank you, Christina. Thank you for having me here. Good afternoon, everyone. I'm really very happy to be here and share some of my clinical knowledge as well as some of the experience that has changed my practice. And and I'm happy that I'm sharing with the people who are working in the same platform of interest as mine. And I'm pretty sure it'll be a nice learning experience for me as well. So I'm a physiotherapist, as Christina said, working in a private practice. And before I moved to this clinical setup, I did have the opportunity to serve in the hospital and community for a few years. Right now, my practice is focused to the neurological, concussion, and the pelvic floor group, and then I live in Owen Sound here, so it's a retirement community. So we are really a small community, and we are really close in connection with all the Falls Loop and the fall prevention people here, from the retirement home to the long-term care home. So that has been a very nice experience. And as I go through the slides, I will also share how my work experience changed my platform of working as well. So the people that I treat kind of range from 10 to 90, so that's the age group. So moving on to the presentation right away. So balance, I know, as I had given in the note itself, it's a very, very simple word, but it's very complex. So to solve a math problem, you really need to understand the problem first. So what is given, what is asked, and then what are the steps to come to solve the problem. So like that, for us, balance sometimes is a problem, and what we're given is a lot because there are so many factors, so many variables, so many interplays, and so many things that we need to separate, we need to put it together. So just like pain science has taken a good twist in the past decade, our depth of understanding of the brain is now paving us a way to understand the mechanisms. So very simply put, like, if I ask balance, everyone knows to tell that it's a product of an integrated inputs to the body where it's acting like a mechanical system, and that is actually interacting with the nervous system, which is totally different things. And the important point here is it's continuously changing environment. Even like as we are sitting here itself and listening to it, pretty much things are changing because you're kind of listening using your vestibular stuff and you're turning, and so it's constantly, we are moving. Without movement, there is no life. We are constantly moving. So that is the challenge. The challenge is continuously changing environment, even with the eye. Like, you're looking straight into the computer, but still I'm pretty sure in the periphery you all can see some objects in there. So that itself, few things have to inhibit what you are seeing and still help you to focus in here, right? So that is constantly changing and evolving environment. So that is an important aspect over here. All right, moving on to the next one. So simple to complex. I know it's really nice if elephant can balance on the ball there. So why I say simple to complex is, and it's heavily challenged because the input has to be received, it has to be processed, and the desired output also has to happen within fraction of seconds. It's not like, it has to be really quick. Otherwise, we are towards the gravity. So also we have to consider the constantly changing surface environment, like, for example, from a carpet to a hardwood floor, or even coming out from the house to inside the house, from a gravel, from a paved floor into the house, and from a small hallway to a bigger room. So the transition is constantly happening. So in fact, the movement what we see is a tip of an iceberg, and the manipulations that interact in the central nervous system and the body is a hidden part, which is huge. So we're just going to look into the certain things. So what is given and what is asked of us. So moving on to the next slide. So balance. So, it's proactive balance and reactive balance, and these two terms have got different names. So you have a feed-forward system, feedback system, you have an anticipatory pattern, and you have a compensatory pattern. Just for this slide, just for us to be steady and consistent, I'm going to use the anticipatory and compensatory patterns more often, but it's all the same. So all of you know the proactive balance is the one that works to minimize partial perturbation that is going to occur, and the later minimizes the destabilizing effect. Like, once the movement is given, what are you trying to do to correct yourself? So in a healthy aging client, I would challenge more in the anterior posterior direction, and then in Parkinson's client, I would challenge more of the compensatory pattern, because there's two reasons behind it. So in my healthy aging client, like, I really want coactivation happening. So I really want front and back happening, right? And whereas in my Parkinson's patient, I really, because they have this freezing episode, they're really strong in the front and the back, but they have this lateral instability that's happening to them where they cannot really correct themselves. So that's where I would train reactive balance more. So as I'm going, I will kind of give examples in between as well. And I know that this group is a mix of PTs, OTs, and exercise therapists and program managers and stuff. So in between, I'll throw in for everyone what I would be expecting. All right. So that's pretty much, so you need both. That's why I face the arrow both towards the balance word, right? So you need proactive, like when they stand up itself, they should be steady. And then when they move also, they should be steady. So both has to contribute together. So there is an interplay here. All right, going on to the factors, to the next slide, which is intrinsic and extrinsic factors. I've put different, the arrows pointing away from each other because the factors, there are some interplay in it, but certain things, if you correct, you'll be able to get it, and certain things you'll have to just put it together. So it can kind of go in two different ways. So that's why I put it facing away from each other. But the factors are important for the balance. And the next one. So this is the framework of balance and postural control. So I don't have to explain everything in detail because you all know the constraints of mechanical system. What I mean is more like the range of motion and strength and sensory strategies that they have reduced input, and then movement strategies, what they really do getting these input, how they move, and do they have control while they move, what we call as controlled stability and mobility. So movement is one when things are stable, and dynamic control is as you're moving, are you having the stability? And then the orientation in space, and which is more so like your head, eye, and neck coordination patterns, and the cognitive processing, which is, again, how far are they in relation to time and space? So that is a cognitive. So all of you know a lot about this. I'm not going to go much in depth with this. All right, and then going on, moving forward. So over here, the central processing system. So I think my slide skipped one quickly. There we go. All right. So the central processing system, it has to get the vestibular information, the vision, the proprioception, the tactile. The tactile information is a little bit important over here. Like, it's more the sensory system that gets from your fingertips and from the tips of your toes as well, and the auditory system. So the reason why I'm saying that is sometimes I really, really prefer to treat the client. Again, as I said, I'm in a clinical setup. It's different when you guys go to the home and treat. And so in the sensory system, sometimes I really want to make sure sometimes I treat them with bare feet. So I'll come to that a little later as well to explain this over here. So
I'm so sorry to interrupt. Would you mind speaking just a little bit louder, please?
Sure.
We just have a few people who are just having a little bit of trouble.
Oh, okay. Thank you.
So
sure.
much.
Sorry about that. Yeah.
No problem.
Okay. All right. I'm just going to go a little bit slower as requested. So pretty much the vestibular information then from the eye, that you have to get the information from the eye, and you also have to get the sensory input, the proprioception from the neck, and the sensory input comes from your fingertips as well as in the tips of the toes. So sometimes it's really, really important that we kind of make sure that all this information goes together. As I said, things have to be inputted first, then there should be processing, and then should be an outcome. So if the sensory input itself is a little bit less, then the processing is less, and then the output is not desired outcome what we have. And after all this input happens, if you see there's it kind of goes into different pathways already. Like system has to go to the thalamus, few things has to go to the vestibular nuclei, and the other one cerebellum. Cerebellum is more like an error correction. So pretty much whatever, when the error correction comes, a copy of the movement that goes to the cerebral cortex, and then it has to come to the cerebellum to correct the error. Again, as I said, all this has to happen within fraction of seconds. So the third column, when we see the central nervous processing over there, you see how many it taking different direction again. As I said, the movement that you see out is just the tip of the iceberg, but what is going on is huge over here, and all these has to interplay. So I think everybody is kind of getting the sense of what is given to us now, like you're understanding the problem, like what is given to us here, right? And so from there, the central processing nervous system that it has to get, and then immediately it has to go to the output section as well, which is like conscious awareness of the head and the movement, and the eye movement, and the head movement. All this get connected to the trunk, and then you have your extremities that has to work. And if people don't receive a proper copy to the cerebellum immediately, then that's when they have this nausea and vomiting or the vertigo sensation, and then the altered consciousness. And again, even this, if the system output is not happening properly, if it is not processing, the outcome also can be negative, like more of a vertigo and the dizziness that comes in. So remember, all this, one of the problem equation over here is input, processing, as well as the output, and these happening in a shorter period of time. All right, moving on to the next slide. So posture. Balance and posture goes together, so I do have to touch on posture here. Posture definitely has some modes of control. So pretty much, say somebody is standing here, and then normal healthy client, like, healthy aging client, let's put it that way, standing here, and then if I just nudge them a little bit, where do you think the first, simple, just a little bit, then their first strategy is going to be in the ankle. They'll just do a little bit of an ankle strategy. Say I'm giving them a little bit of more of a push, and then immediately the next strategy would be the hip strategy. So that's where the first correction happens. And sometimes the brain actually needs some reference points. Say I'm asking one of you to just stand, and I'm asking you to stand in a single leg pose, and in a bare feet, and then I'm asking you to step onto a foam platform, and then asking you to do that. So just for you to get it, you might just correct yourself with a little bit of a fingertip reference there. So sometimes it's just that light touch. That light touch is really not taking your body position there, but it is a reference point to the brain that is just saying, okay, that extra input that you got, and then it's able to process it, and then you're standing a little bit balanced for the next 2 seconds or something, right? So sometimes it's better to use those reference points as well. So this is where my other point comes, like practically applying. So practically applying, when they do like more of a grip strategy, you're trying to teach them and they're holding on to something, that means you're sending the reference system too much reference system. Your sensory input is a lot, right? So because when they're walking, they're not going to walk along the wall, touching a surface all the time. Your main goal is for them to walk from point A to point B, stabilized. So try to tell your clients to give that reference point lesser and lesser as you are training with them. That'll give them that confidence. So there is a practical point in there. The third point is trunk gain and leg gain happens when I push someone, like when I do a perturbation, right? So the first thing that I want to see in a client is they need to correct it with the trunk first before they move their extremities, right? So that is really important. So because trunk is kind of your stability piece. If you take a human body, the trunk is more like a stabilizing part in between, and the extremities are connected. Like your upper extremities is connected to the upper part, and the lower extremities are connected to the lower part there, right? So pretty much your middle piece is trunk. So you really need to gain a trunk gain first. They should try to correct it with trunk before they do a leg gain, right? So that is important. So this is where I would like to throw a practical tip to all the exercise specialists that's there, like kinesiologists and activation people and stuff. So it is really like you can always give the feedback, because when you do little exercise classes, I give feedback to the therapist that when they come back for treatment, or if somebody is doing a group exercises in the retirement homes or anywhere, so the exercise specialist can see they tend to move their leg more often. I see less of trunk stability. You can always give the feedback, and the OTs and the PTs can work with that. All right. Moving on to the next one. People with vestibular hypofunction have less trunk gain. So what I mean is, say people, so over here your assessment can come into play. Researchers found, and there is evidence telling that people who ever had both sides, like anywhere vestibular dysfunction, like meaning your infection, like just often on and off during their lifetime, they apparently somehow compensate with their eyes, and then slowly the vestibular function reduces, and those people apparently exhibit less trunk gain. And as I said, you really want to gain the trunk first before the leg steps up. So those are some things that you can kind of assess or ask them their assessment itself, right? So these are some important modes of control and posture, and just the little things that little pearls that will help you to do that. And then reduce sensory input shifts the compensatory strategy, meaning say they don't have enough input, even with holding on, they don't have that grip. So this is where finger tips and the toe tips come into play. Say somebody has hallux valgus or a claw toe, so they are pretty much not using their sensory input much, and if they have their shoes on, you really want to be able to see what's going on in their ankle over here. So when I do my assessment itself, sometimes I try to do it in bare feet just to see what it's doing, what is the body really doing when I do that? Did I see first in the ankle, then did I see that in the hip? So again, an assessment part that comes in here. So if there is reduced sensory input, you will automatically see leg-driven more than the trunk-driven compensatory patterns. All right, moving on to the next slide. So a little bit more on the visual, vestibular, and sensory integration over here. So I don't know how many of you have heard of head-on body movements and body-on-head movements. I'll explain that a little bit. So head-on body movements is like your head is stable, and then I just ask them to turn their body side to side. Say, for example, you're just focusing on something. The OTs might know this a little bit better than, and I'm pretty sure some PTs do know. So you're going to ask them to fix their gaze on something, and then you're going to ask them to bring the shoulders a little bit forward, like as if they're turning their trunk, and in sitting position itself. And the other one is body stays stable, and then the head moves side to side. So sensory organization, it's really important. This head-on body and body-on-head movement is really important, and people really don't know how much they miss. So that's where your head, eye, neck orientation come into play here. And that is an important aspect. So sensory organization, this involves a complex process that determine the appropriate timing, and this also has to happen in a certain timing, direction, and amplitude of corrective partial actions from the incoming information, so like the visual, vestibular, and somatosensory. So there are 4 reflexes that's in play over here. So one is the cervicocolic reflexes, which is like this stabilizes head in respect to trunk. And the next one, I'm actually going to go to the vestibular-colic reflexes, which stabilizes the head in space. Now, these two together will contribute to the next one, which is the vestibular-ocular reflex during head movements, which is your eye movements, because even as you turn, your gaze has to be fixated. So that will also help. So I'm just going to use it as CCR and VCR for you. I put that in the bracket over there. So the first and the fourth will kind of contribute to the second one, which is the vestibular-ocular. And all these 3 will kind of come into your vestibular-spinal reflexes, which actually stabilizes your body in space. And just as a little note, I just want to say that the ratio of the head-to-eye movement gain that they say is actually 1:1. So, and if it is a little bit more or less, and that's when you get blurry vision or vertigo that really happens in there. So, one more point here is the VCR, which is the first one, and the third one, the VCR and the CCR, are both our compensatory reflex pattern. As I said, the compensatory means once you started turning your head, it has to correct itself right away. And these both are important to the VSR. So now coming to a practical point in this slide, these are like little puzzle pieces. Like, I practice all these different set of reflexes in my session. So coming to a practical point, definitely it's important. Say somebody has a history of fall, and they are actually having a few falls. Just do a basic oculomotor screen, very basic. OTs know to do that, and if PTs, you guys have done any concussion courses, they will teach you that. Just very basic. We are nowhere near the optometrist group. Like if it is a little bit more than our scope, I recommend that you send them to the optometrist explaining your concerns. But definitely you can do the basic. Are they able to fix the gaze? Are they able to have a smooth pursuit, meaning just look around from side and then are they having difficulty? You can make them do them in sitting and then standing again. So in these things, I really want you to practice. This is, as I said, these are all like puzzle pieces that I want you to practice in your sessions. Just see what they can. And certain things you really don't need to overdo it. Sometimes I tell my clients, just do it twice a day, because certain things the brain just has to know how to do it. You really don't have to practice it 100 times. Then they'll say, I did it too many times and I felt dizzy. Like, no, you really don't want to do it 100 times. But it has to align for the pattern. It has to remember that pattern. And also one more thing to remember is as they age, their periphery, they are losing their peripheral vision, right? They become more centrally focused. Same with people with concussion as well. They become more in the like people with concussion, since even if they fall and they hit the head at that time, at least for the next week, they are going to be more focal. They're going to miss a lot in the periphery. So the head, eye, neck movement puzzle, it's a puzzle piece. So please make sure that you incorporate that in your sessions. So that'll be really, really very, very helpful. Initially, even in the initial days of my practice, I was kind of working more, range, strength, and then as you evolve, you think, okay, this is a good piece. So I train them, and then I give them as like a home exercise program, because that much is good enough, because you really don't have to waste time on that. And then when you are actually putting them into work, say, for example, you're asking them to walk, ask them to just scan the room from the left to the right. And if you're in an exercise group, as they are sitting, you can just ask them to scan from the left to right. Go from this person onto your left and come to the person to see onto the right. So you're kind of practicing that. And then you can fix a target over there at one point and say, okay, turn your head to the left, but keep looking at the right. So things like that, which you can do it very simply. Again, putting them into a group is different, but these are some little pearls that you can put that into your practice. So as I said, these are puzzle pieces that you can practice. And then finally, when you functionally integrate, you can put it together. And definitely, I have seen a difference. So obviously, I'm pretty sure all of you also will see that difference. All right. I'm moving on to my next slide. So a vital checklist. So pretty much over here again, we kind of discussed certain points with that important thing, and as I said, we are navigating balance. So what all is important? Over here, with anticipatories, the verticality and appropriate orientation. First of all, they really need to stand up straight, right? Only if they sit properly, they can stand properly. Only if they stand properly, they can walk properly. And most of our people, and again, if they are very inactive, they are constantly in a posterior pelvic tilt, and then they are held in that position for good hours. So in fact, the trunk even is not turned on when they get up, and sometimes when they push through their hands and get up, so the legs are not even turned on because hand is doing most of the work, right? In that case, once they stand up, it's going to take a few seconds for them to even get every input into the system, and then it has to be processed. So it's really, really important. Even before they stand up there, you need to turn on the trunk. Tell them the importance and assist them to turn on their trunk first, go a little bit forward, and then to stand up. Of course, we have heard so many presentations and everything on doing a proper sit-stand transfer, but I really request PTs, OTs, and people just to make sure that they turn on their trunk even. That'll give that stability to stand up there. The second thing is impaired reactive control. So first thing is standing up and being prepared, and the second thing is when there is an instability, when there is a perturbation, are they able to come back? Are they able to correct themselves? So this is where in your assessment itself, you can see, okay, what are they gaining it from? Are they gaining it from the trunk first, or are they gaining it from extremity first? And then you'll be able to navigate, okay, maybe I need to do some trunk strategy first as I'm doing some leg strategy, so things like that. brings me to the next point here. It says we have to be careful in selecting, asking the questions, or like, am I screening for the fall risk, or am I doing this assessment for an intervention selection, or what do I do for treatment per se? So over here, it's not in the slide here, but I just want to give a little bit of an example here. I kind of reviewed a little bit of a few papers from a meta-analysis paper, and here they were seeing 369 individuals who were part of survey. And pretty much in meta-analysis, it says that 60% of the people regularly assessing postural alignment, static, and functional balance, which is really great, right? And also there are several systematic reviews in Cochrane Review, and I think the one that I picked up was by Gillespie and et al., which is 2009, and they included 111 randomized trial. So in this trial, they have seen that assessment and multifactorial intervention have reduced rate of monthly falls, but not the number of people. And then the home safety interventions has reduced the rate of fall, but not the number of people. But it was very effective for people with visual deficits and for others who were in high risk of falling. And the change of medication had reduced rate of falls, but not the risk of falls. So you can see how even the assessment itself is going to screen things for us, and then that will be able to, if you choose the right assessment, you'll be able to choose the right intervention. And with the right intervention, your treatment strategy is going to be the best. All right, so that's it with vital checklist. All right. So now you know certain details. Now you know what is given. Now we know certain aspects, how it is important. Now we are really going to a starting point. Okay, with the starting point, what do you do? It's a fall risk assessment that you do, right? If somebody is coming to a clinic or community practice, if there is a referral you're going to see, you're going to do an assessment first. So again, I just looked into the standardized fall risk assessment test. They were between 66 to 68. I went through a lot of papers, and I found there were mostly 66 to 68 papers. 68 validated standardized tests that overall people are using. So higher proportion of these tests were measuring only few components. Of course, there is no test that is measuring all the 6 components that we saw in that slide where there was a framework for posture. There was no such test that would check everything in it. Definitely there were a few overplays, like interactions in there, but not all of it. But on the brighter side, it also says that recent tests, like best test is all recent, and the evolving test is also continuing to widen the different combination, which is really nice. So what has been clinically researched, we are able to apply practically, which is lovely. Good. I'm just going to continue on that. So functionally relevant components are missing. For example, certain tests, the reactive partial control and corrective responses, and the instability test were there only in 23% of the tests. Like, in the 63, only in 23% of the tests, these things were tested. So make sure that when you're choosing the assessment itself, like they're all validated, they're all standardized, but I think when it comes to practitioners, we really apply all that research brains that has given us. They have done a lovely work of research, and when it comes to application, I think it's really on us to kind of take it from there. Okay, what am I testing? How is there anticipated? What all tests can I do in it? Because even doing the test is time consuming. Like, even if it takes 10 minutes, but that is a valid time of yours. That is a very incredible important time. So taking time to do that assessment, first of all, picking the assessment, and that's my request is, let's not stick with just the one that is standardized. You can pick and choose, and you can then that when you choose that, it'll be very easy for you to drive to your treatment strategy, and then from your treatment strategy, you can see that outcome measure that you wanted to gain. So, and this, if it is regularly implemented, I'm pretty sure, we'll be able to see better results more. All right. The next one. Oh, and I do have a list of all the 66 tests that I have typed it out, and I will send it out with the slide of text as well, so that you know what all the tests are there, and then you'll be able to make that informed decision. And I will also send out the articles that I took it from, so for you for more reading there. All right. Now coming to the application point. Quite interesting. So given the significant time and resources that we invest in administrating the standardized measures, it's very important that we optimize that into clinical practice, right? For example, say in my assessment I see somebody has got a hallux valgus in there, right, like the toes turning outside. So that means, say if it's kind of a moderate to severe, then right there that'll tell me that the last phase of their gait pattern, which is a metatarsal roll that has to happen, is going to be affected because they have hallux valgus. So obviously that roll is affected. If that metatarsal roll is affected in the toe-off phase, that means their hip external rotators are really, really tight and they are kind of turning in because they would have had compensatory patterns. Right? So that means I will automatically include strengthening of the external and internal rotators of the hip, make sure they're in alignment, do they have tightness along the ITB. So just that assessment gave me that treatment strategy, and then what can I do to prevent further decline. And OTs, if you're looking into that, definitely please suggest them some toe separators. Gel toe separators, I'm pretty sure, hopefully there's no skin issues. The gel toe separators have been really helpful for certain people, but if it's long gone, you could discuss it with the OT and PT when it combined. And as I said, I'm very much holistic. Even in our clinic, it's very multidisciplinary. If there is a functional group that is there is an OT that is present. We are very happy that we are able to incorporate that in our clinical practice here. So, and OT is there for all our group session for our balance class. All right. Next one is proprioceptive task improvement performance. Again, the OTs play an important role over here, like to improve the sensory input through their feedback, through the fingertips and the toe tips. OTs, you have the magic hands there. You will be able to bring a lot of sensory integration tasks here. And just all this application, when I come to my example 1 and 2, I will explain certain things like how we did that in our clinic so that hopefully it's helpful for you as well. And coming to all the community resource program that we have, it's really great that we have all the resource program, like for example the VON exercise group, or if the retirement home has an exercise session from the activation group. So they're all really great, which will address certain factors, right? So if they are going in there, or if they are asking the OTs or the PTs help to set it up, just make sure you include all that 6 component, that modes that I taught are incorporated into that. And sometimes the very basic one that they're doing outside just has, they just have the first 3 components, like, for the range, and then they're doing the stretch. They have that. They're really, really great. But what is the next step? Just doing that alone will not reduce falls. That's where you really need to say, okay, just review that exercise with them. Okay, this is what you're doing there. You're missing this puzzle here. Can you practice this as well? Right? That's where it comes. So review their exercise with them. Hopefully they'll remember the exercises for you there, or see or attend the group once and see what is there. Or even I really feel OTs and PTs can give their input to those exercise group and say, hey, can you add this? It'll be really lovely. And that's what we are working on, is to work as a team all together. So extremes are easy, so like, doing it too slow, doing it fast, really easy. Strive for balance. So when they're doing the movement slowly, that's when they struggle. So when the movement is slow, that's when all the muscle has to be turned on. And remember, for a movement, it's not one single muscle that is acting. For a movement, it's a couple of muscles that's acting, the front and the back and the side, and they all have to turn on and turn off at a certain time. And that is really, really important. And until they get that, some people, when they ask you to do something, they'll do it quickly and they'll go, it's easy, right? Because they're just turning on the superficial muscle. They're not turning on the stability muscle. So we really encourage people to kind of do that movement slowly. So, all right, I am moving on to the next one. Example. All right, so I know I've been touching base with the little puzzles, and I gave you some practical tips here and there. Now I'm going to come to an example that I have an example 1 and I have an example 2. I'll tell you what I did and then what was the outcome. So I had this 65-year-old gentleman. He came to me. He said, I don't have any pain anywhere. And he said, I'm just bumping into things, people, and no matter what, that's what I'm doing. And I have difficulty orientating when I come from a narrow hallway to a bigger hallway, to a bigger room. So I'm thinking, oh my God, he doesn't have any pain. What do I do? Normally it's the strength and the range. He says, no, I don't have pain anywhere. This is what it is. I'm bumping into people. What's going on? So that was a challenge to start with. And then I thought, okay, talk to me. So I'm just going to give you a little bit more details on him here. So he was a retired teacher, and lately his spouse was there in the session too. So she was telling me that his falling frequency has been increasing in the last 3 months, and apparently last 3 months, but this ongoing problem where he's bumping into things, it's been going on for like a year and a half. And he did try chiropractic, massage, physiotherapy, but nothing worked. And the only one thing that I saw was he had some right shoulder problems from a previous injury where probably his flexion and abduction was only about like maybe 60 to 70 degrees. That's all he had. And he said, sometimes I asked him, and he gets up, I wanted to see what his anticipatory passion was. So, and I said, if I stand up too quickly, he says, I'm a little lightheaded, but he said, I'm not dizzy though. That's what he said. But otherwise, he had no pain complaints anywhere. So with this, it was very, very clear for me that he had trouble with his head-eye-neck coordination. Remember the CCR, VCR, VOR we talked about in that slide? So that's where he had that trouble, and that was not orientating into the trunk gain. And obviously, I saw more of a leg gain before I saw a trunk gain. That's what I saw in him. So, and then I asked him if he was able to read things, So with this, and he said, well, I read it, but I really don't understand things, he said. I have to read it twice, he said. So immediately the test that I took was, for him was, I took a ABI vision questionnaire that kind of asked about the reading, and I also did MTSIB, like the sensory test integration for balance, and I did a BEST test. So these are the outcome measures that I chose. And then I checked his neck. So there was a lot of tightness in the neck, and he was not able to do a trunk movement at all, like the head on the body and the body on the head. I asked him to keep his head fixated on a point there, and I asked him to turn the trunk. He couldn't do it. He only went like halfway. And so that was very, very clear to me that he was very, very focal. He couldn't see anything in the periphery. So when the periphery is not there, he doesn't even know that it's there. He's going and bumping there, right? So my intervention strategy was really very clear there. So I gave him gaze stabilizing exercises. I gave him a little bit of a smooth pursuit exercises, very, very simple. And in a way, I also wanted him to go to an optometrist as well, just to see the field and periphery and just to make sure. So I also made that referral to an optometrist. So this is what I practiced with him. And then so this was also home exercise program. And I did some soft tissue mobilization for the neck, gave some stretch reflexes for the neck, and we did a lot of head and neck movements. As I increased the proprioceptive responses to the neck, he started getting it better, and I incorporated that functionally. So I would just swing a ball in front of him, and I asked him to turn his head, or just look with the eyes first, and then I asked him to turn his head back and forth. then we did that as he is turning his shoulders front and back as well. So slowly I added components after components with that, and then finally I put all that together while he's walking. Like, you walk and the head turns and you are tossing a ball. We have done that. But again, there was a hierarchy that I took. First I created the head and the eye, and then I connected the head and the eye to the neck. And then after I connected those three, I took it to the trunk, and then I added the extremities. So that's how I put it together. I actually treated him once a week for 8 weeks, and then I treated him every other week for another 4 weeks. But in between, but luckily he was a client. If I say do this homework, I'm pretty sure, he would do it. Like, whatever you ask, he would do it. So that way I was lucky. So. And he did the puzzle pieces separately at home as well. So I was able to put it together when he came to me. So that was really a lot of problem with compensatory patterns. And then the treatment outcome was he's not bumping into things now. He had more of a trunk gain in my last session than his leg gain, and he was very happy. Last I sent him to skill builders too because of his thing. He himself weaned off from driving, and after he gained it, the optometrist was also okay, and now he is back to driving. So he's enjoying his retirement life, he says. So that was a very nice example. So that is one example, and I'm going on to the next example. All right, another one was a 55-year-old Parkinson's client, and he was very recently diagnosed with Parkinson's. So very recently in the sense before he came to me, I think it was about a month or so, he was diagnosed. And he came to me telling that he had difficulty turning and he was unable to walk confidently, right, like even to stand. Of course, very, very clear for you. He had trouble even with the he had trouble even standing up. He had trouble, and he didn't even turn on his trunk. I know he was diagnosed recently, but his posture was not great at all, and his trunk was not working over here. So over here, I took the test that I took was a multi-directional reach test because his falls were more like when he's trying to reach for things, and he had a lot of lateral instability. Like if I just be at the side and nudge him, he was afraid. Immediately he will grip and grasp. So he was doing that. So I really had to turn on the trunk. And the other thing that I noted in him was he had reduced dorsiflexion. That means there was not enough stretch reflex going into his calf at all. So that really didn't direct his knee, that really didn't direct his hip. So, there was that problem there as well. So with him, I gained more range in the dorsiflexion. I turned on the trunk all the time. We worked on a lot of trunk to neutral exercises, and for him to know that he was thinking being forward was neutral. So a lot of biofeedback with videos and mirrors and just being against the wall. So a lot of biofeedback, and I happened to really do a lot of trunk work in there, and that really helped him. So that was the intervention strategy. And then with the trunk, I also, as I got the trunk turned on, after that I worked on lateral stability, like the side to side. I made him sway a lot in the side. So if I push him to the right, he has to come to the left immediately, right? Like that's the strategy that goes on. It was difficult for us. He didn't gain that for the first 4 weeks. I thought, oh my God, should I change my pattern because I'm not seeing. I did 2 to 3 sessions. I'm not seeing it. But then that's when I saw that he was also clawing, like the sensory input wasn't there much. So the OT came into play, and she helped us with some strategies, and then he was able to turn on it better. And after that, a lot of functional patterns that we inputted was very, very helpful. So right now, I think this is my 6th week with him. I saw him twice a week. This is my 6th week with him. He's confident of standing up. He's able to, I didn't do the I didn't do any timing for him yet. Maybe I should have done. But he's able to stand up better, and he's able to take 2 to 3 steps without any gait aid. So that is giving him that confidence. All right, and just a little to touch on, we do have group sessions here in our clinic because there was a lot of requests for it, and we did it. In these group sessions, what we basically do is there are stations. So the physio, so in this group session, I had a physio, I had a kinesiologist, and luckily we had a student for the summer. So we were able to put all these people together, and so we had stations. I only took 4 people for a group. I didn't want more than that. This was more like a trial as well that we did. So there were stations. So first the physio would do soft tissue mobilization just to give that stretch reflex wherever needed after the assessment was done. And after that, they would just move on to visual vestibular exercises. That is a circuit station. From there, they would move to strengthening exercises, and from there, they would move to functional exercises. So they kind of did that in a circuit. So everybody has to complete everything. Maybe each took about 10 minutes, and they took a break in between. So this is what we did, and we are kind of in the middle of that. We didn't finish that, but the 4 people who came in, they said that they are feeling a little bit confident, and their spouses or family members are seeing that they are a little bit more straighter, and at least they didn't fall so far, which is a good thing. So we are in that trial for now, and we haven't given out. Seen the results yet and the outcome measures I have to do. So, all right. So I think I'm on time. So that's been going on. I really hope this helped you. And if you have any questions of I know it's very hard to explain these things in a webinar. If it's in person, you'll be able to see. But I'll be very happy if you email me or call me. We can discuss, and I'll send details for you. Now Christina, am I on time for questions?
You are on time. We do have just a few.
Sure.
And just a reminder to anyone, if you have any further questions for Deepha, you can type them into the chat box in the left-hand corner. You can also press *7 to unmute your line, and you can verbally ask your questions as well. So I'm going to just read a few questions in the 7 minutes that we have left, Deepha, if that's okay with you.
Sure.
Okay, so one person was wondering if you are able to provide some examples of good balance exercises with visuals, and perhaps is there a way that we could share that with everyone after the webinar along with your other resources?
I'd be happy, but I just don't know how to do it. Do you want me to video it and send it to you? That's possible.
Okay, so perhaps you and I can discuss some possibilities.
Yes.
For that particular question.
Yes.
Okay, so another participant was asking about the outcome measures that you used in example 1. She just didn't catch them, so we were wondering if you could repeat those.
Okay, sure. Example 1. Oh, yes, ABI questionnaire. It's called it's for post-trauma. It's a concussion questionnaire. I can send it to you. I got that in one of my concussion courses, and they said that it is available. And then the other one I did was clinical testing for sensory integration and balance. That was the one. And the third one I did a BESS, BESS.
Okay.
Yeah.
Okay, thanks for that.
Okay.
There was another question about elaborating on the terms trunk strategy and trunk work.
Okay. So trunk strategy, trunk work. All right. So pretty much it's just turning on the trunk. You want the trunk extensors to be turned on. So how I would do that is probably if you have a treatment table, I'm just again talking in a clinical setup. If it's in a home, it's different. So make sure that the pelvis is a little bit neutral or an anterior to that. Itself will turn on the trunk, When you're slouched, to turn on that itself will turn on the trunk. And the second thing is you can kind of train them from stooping forward. If you make them stoop forward a little bit, the trunk will turn on. And then you make them do some strategies where you're asking them to stoop forward. They're sitting at the edge of the bed, and then they're going to stoop forward, and then they're going to reach to the far extremes. You can be nice. I know my people always know that I will move my hand back and back, So make them to reach forward. So that means they will use that trunk muscles to kind of keep their stability. And as I said, trunk is your stable base. You need to gain that base for that. So those are some strong strategies that I would use.
Okay, so related to that question, Deepha, is a question around any core strengthening exercises that clients with Parkinson's can do to help drive the trunk and not the legs?
Core, again, once you turn on the trunk muscle, the core, just them sitting and standing itself will involve the core, Just ask them to practice without using hands. A lot of the people just push through their hands and get up. We really don't need hands to stand up. That being said, even I've done that often. Like, how many of us do it? When you stand up, you use your hand to stand up. Do we really need hand to stand up? You just need your core and your trunk. So when you use your hand, your sensory input to your leg is already gone, right? So when you don't use the hand. So core strengthening you can work, but sometimes also you should remember, if you're going to give them core, Parkinson's clients get fatigued easily too. So you have an on time and an off time. So I would maybe be in the happy medium. See how their core is, be in the happy medium. But every time they sit and stand, they stand up without using their hand. That itself is core involved in function. That's my answer.
Okay, great, Deepha.
Yes.
You mentioned some group sessions.
Yes.
Can you share with us the outcome measures you are using for the group sessions?
Just two. We always do a forward reaching or a multidirectional reaching. That's the one we do. And the other one we do a tug test, like get up and go test. Just that. We keep it simple, and then, again, as I said, we are in the middle of that thing. I haven't seen the results yet. This is just out of our interest that we did.
Okay, and then there's one last question that we'll end with.
Mm-hmm.
Can you specify what you mean by gain? And you had mentioned that around slide 7, 8, 9.
Yes, trunk gain and the leg gain. So what it is say somebody is standing and I give them a little nudge, right? They have to correct it first with the trunk. That's what I call gain. The postural stability that they gain through the trunk is the trunk gain. And if they gain through their leg, it is a leg gain. So you really want trunk gain first before leg gain.
Okay, Deepha, I think those are all the questions that we had. So thank you so much for going through those.
Sure.
I'd like to thank you again for your wonderful presentation, and to all the participants today for joining us and engaging in a great discussion. Please don't close this window just yet. You will be directed to the next screen, and then it will be safe to close the window, and a brief evaluation survey will launch in your web browser. And we'd really appreciate if you could take a few minutes to provide your feedback so we could continue to provide webinars. For more information about the Fall Prevention Community of Practice, please visit us at fallsloop.com. And we want to thank you and have a wonderful day, and see you all next time.